So I want to introduce the next session called Digital Health Grows Up. Dr. Aenor Sawyer is going to be leading it, and I'm going to invite them to the stage. And I'm going to close down Reed's computer here. Get a whole couch. Thank you.
We could. I would have liked to watch the Warriors from that couch, but it was a good game anyway. Thank you very much. Now all I need is the controller. This panel is basically talking about how digital health has been growing up, and it's been growing up very, very quickly. I think we're going to chase Reed down and get the let me see if this one will work. And what we want to do today is talk about where we've come, how far we've come, and how fast we've come. And it'll go faster when we can advance the slides. But in the context of several different categories. One of the categories we're going to talk about progress in is in the area, obviously, of investment and finance and business. And this is an interesting statement to me that I found in doing some of the homework. Back in 2002, you can see that Forrester did a really nice report, and this was one of their top 10 predictions, that in that year, e-health, or what we now call digital health, it was growing up that year, because there had been lots of work going into it up to that point. So it was an interesting finding for me, and I went through and read the report, and it was very optimistic. But what it said to me is it's a really, really hard field, because even now, more than 10 years later, we're still growing up and going through growing pains. But I thought this was a phenomenal statement. I would really like to advance to the next slide now. Oh, great. It never fails, I always say. If you're putting on a digital health conference, there's going to be a digital flail. So I'm hoping we've gotten through ours now and we're going to start sailing. So when we try to figure out how we're doing in this field and is it growing up, are we going forwards or backwards, we look at it a couple of different ways. Certainly we, on the healthcare front lines, and I'm sure most of you as people who ultimately contact healthcare, you want to know if it's working. So we want to know if we've got improved outcomes, better workflow, communications, patient engagement. We also want to know from a business standpoint, does it have a sustainable business model? Have we achieved a point where, for many of you, it's a big concern that it's profitable, but even if it's a not-for-profit, it needs to have a sustainable business model. So have we succeeded in that area, or are we making progress in that area? And our good friends, Rock Health, who we work closely with right across the street, have given us lots of good data year to year. And I won't read all these, but just a few are important to show us that just in the use and the reliance on mobile health and digital health, 84% of doctors are using tablets now, so they've got the medium and the devices that they've been adopting. And 19% of smartphone users have health apps. I think it's higher than that now because it's been accelerating every year, and that was in 2012. And 59% of physicians think that it's all happening, it's coming, this is inevitable. And this is an interesting statistic where 3/4 of people, adults in the country, look up healthcare information. The irony is 77% of those look it up on search engines, and only 13% really go to healthcare sites. Again, hopefully that's changing as those healthcare sites become more useful to them and more meaningful. And physicians are now spending twice as much time getting information in a digital format than in a print format. And also interesting is that they're relying heavily on Wikipedia, not just their medical source information. In 2014, it was a dramatic year for digital health. If you look at it just from the funding side, $4.1 billion went into funding digital health, and that's really nearly the same as the 3 prior years in total, and 125% growth just over the last year from 2013 to 2014. This is only counting deals above 2 million because they're easier to track. But there's a prediction that by 2017, in just North America, this could go as high as 31 billion. And it's certainly outstripped device, as most of us know. So it's an extremely hot area, and as one metric of success, that is success, and it's growth. It's not the only metric, though, but what we can see is that there are certain categories that are of most interest, at least to the funders. That doesn't mean that those are the white spaces that we necessarily should be working on, but they do some homework to try to find out if that's the right area to invest in. I won't read them off to you, most of you know them, but the interesting thing to me here was that personalized medicine finally made the top 6. And it's interesting because a lot of people haven't really understood what it is. Personalized medicine, precision medicine, et cetera. But most people know that they want to combine data to make more individual optimal choices, and that's precision medicine, or what we're also calling informed health. But it's interesting to know that the number of investors in digital health has increased as well. So there are 3 times as many from 2011 to 2014. And these are people who are doing 1 to 2 deals. The number of serial investors, so 3 or more, is also on the rise, and repeat investors. And I want to take a moment and thank several people in the room here. You'll see there are several groups in the room here, investors, who are actually fueling the engine of digital health innovation. And I really thank you for coming and for your efforts to make this field excel. There are 3 areas that I think are going to be hot topics going forward, certainly from research and reports that are being done by agencies. Telemedicine, so thank you to Dr. Tuxen for setting the stage for that. Payer administration, and also in that, healthcare delivery administration and workflow efficiencies. And then digital therapies and more care outside the building and supportive care. It's very, very exciting. There's nothing else to say about it. We have disparate data sources that we can now associate if we build the technologies for it that we've never been able to before. So I've started calling this the panome, but we get data from many different sources, including genomic data, but also consumer analytics. And the ability to make associations such as the number of people you call on your cell phone that's being tracked anyway with severity of depression, which Ginger.io did a nice study to show that means that some of these things that are cheap and free and being collected already might become biomarkers for early detection of deterioration in diseases instead of waiting for the devastating moment of attempted suicide. So I think it's a very important opportunity for us, but we have to figure out how to get that data into information. So we do a lot of scientific, rigorous work here at UCSF. We also like to think we're innovative and on the front of the wave, but most of the time now we're feeling much more like this with the onslaught of data. So what we need to do is figure out how do we get that data first acquired and synthesized in ways that we haven't ever done before, and we have technology and we're starting to experiment with that. But how do we make it actionable? How do we contextualize it so that it becomes meaningful to us? And there are many steps to that, and the overall word for that that's being used is interoperability. Another big need is the need for evaluation. So this is an area moving out of finance, is we need to know if these things are effective, not just in cost, but effective in care. And that's really important to us. We feel like we're not the only ones asking anymore, not just the scientific nerds or the healthcare providers, but also the consumers are asking, the payers are asking, and certainly the investors are asking. And there's a paucity of research in this area, although it's finally starting to accelerate. And I think a good person to follow in this is Alan Lebrick at Hopkins. He continues to look at how many articles are being published in peer-reviewed journals in mobile health, and it is accelerating. If you look at the bottom number, there were 40 new studies in the last 6 months of 2012, and that's continued to grow, but certainly a paucity before that. And we need to understand the methodology of studying digital health, because it's different. The intervention continues to change while you're actually doing the study. Another area that we need help in is how do we actually get these technologies adopted? And this is a multi-faceted problem, but I think one thing to think about is, do you really know your audience? Do you know your user? Are we bringing enough design thinking into the process up front? And more will be talked about this afternoon on that. But also, do we understand the workflows? Do we understand from the delivery side, what are the white spaces? So lots of questions about how do you actually get the technologies implemented. So many people call it the last mile, but how do you actually get these technologies embraced and integrated into the healthcare delivery process, if that's where they are, or into the consumer's lives, if that's where they fit? And we typically get looked at as being at this end of this beautiful diffusion curve, which has held up well since the 60s, a little better than I have probably. But we're actually considering ourselves at UCSF over in this area, and I think all of my healthcare colleagues are actually at the innovator side, because even when a patient's individually sitting in front of you, you are innovating and creating trying to understand what would be the best way to optimize their health and their life. But needless to say, there is a problem with adoption, and how do we get through that? So lots of excitement, lots of hype, lots of more than hype. We actually see that digital health is growing up, but I would say that there's a difference between growth and maturity, and anyone in the room who has teenagers probably understands the distinction already, that teenagers end up with very large bodies, and actually their brain gets large, but well before the gray matter that they need ultimately is going to all be laid down. So it's analogous to me that we're probably in the adolescent phase of digital health innovation. So instead of it grows up, we're calling it is growing up. And I'll stop at that point because I have two really fantastic speakers on the panel today, and I'd like to transition over to them, and then we'll just have a great discussion. But they're going to have each a period of time to present some important topics to you. The first person I'd like to introduce is Dr. Roy Smythe, who is a thoracic surgeon, practiced at MD Anderson for a number of years, and has been a leader in healthcare from the clinical side and the administrative side. And now he's the CEO of Avia Healthcare, or Health Innovation. I'll let him explain what that is, because we'd like to learn more about that. And also, he's the CEO of HX360, which is a new entity within HIMSS, so make sure you look for that at the next HIMSS meeting. But it's a lot about getting technologies fully integrated into healthcare delivery. So I'll turn this over to Dr. Smythe.
Well, thanks very much, Aenor, for inviting me to San Francisco and to this meeting. It's a great honor to be here. There's obviously a lot of things we could talk about. What Aenor asked me to discuss is if digital health is growing up, why is it still so difficult to see the fruits of the labor? And that's what I spend a lot of my time thinking about. So I'm going to talk just for a few minutes about some of the impediments that we have integrating the amazing digital technology into the delivery system. Louis Sullivan was the father of modernism in architecture, and he had this crazy notion that these beautiful Gothic buildings with gargoyles and ornamentation should actually, rather than just look good, should actually promote the functions that were supposed to be going on inside of them. So he has this quote that form ever follows function, that you should design things or structure things to facilitate the activities that you want to actually get done. In healthcare, we have a form and function mismatch, and that's one of the reasons why, even though digital health is growing up, it may not have a place to land as effectively as we'd like. I wrote about this a while back in Forbes about what I call the major impediments. There are hundreds of impediments to change in healthcare delivery, but I think these are really some of the basic ones, or the ones that sort of underlie many others. The first is a focus on diagnostic and treatment tools and exclusion of other things. Now, we need great diagnostic and treatment tools. We all want to be diagnosed and treated effectively when we interface with a healthcare delivery system. But we've actually focused on these tools to the exclusion of many of the things that you're producing or would like to produce or would like to use. And we'll talk about that momentarily. The yoke of previous success. The previous model is not the model that we're envisioning. And the previous model has been very durable for about 100 years. If you're a little bit sick, you go to a small box, see one doctor for a short period of time. If you're a lot sick, you go to a bigger box, see a lot of doctors for a longer period of time. And the structure that we put and the processes that we put into those boxes facilitate that model. There's a lot of sunk cost in that model, trillions of dollars of sunk cost, right? So buildings, people, support structures, ancillary businesses, ancillary industries to support that model. How do you dismantle that? It's very difficult. The next, of course, is a poorly aligned payment model. I don't need to go into detail about that. And the last is a risk-averse culture. Healthcare is a risk-averse culture. Physicians are taught to be risk-averse. They're taught to be only using tools and treatments that are proven because, quote unquote, if not, I may hurt someone. So what are the manifestations of these four problems? So in action, the manifestations shouldn't be any surprise. Avia and HIMSS did an innovation prowess survey in 2013 and found out some interesting things. And so I think innovation is a surrogate word. Actually, I think it's executive Tourette syndrome word. It comes out of executives' mouths. I don't really know what it means. But in this context, it's a surrogate word for technology adoption, right? Because that's what we're really talking about here. Adopting technology into existing processes and structures to change the business model and delivery model. 89% of health system executives said innovation was paramount. However, 77% of them said they had no idea how it had impacted the way they deliver care in the last 5 years. And that 43% of them actually funded these things only on an ad hoc basis. So money goes below the line for CT scanners, money goes below the line for hiring nurses and new physicians. But when it comes to that new digital technology that's going to make the primary care docs a bit more efficient, if we have money left over at the end of the year, we'll see about that. I'm going to talk again in a few minutes about the 360 index that HX360 is developing with Deloitte and HIMSS. And we just did an index sort of alpha test survey of health systems, and the index basically looks at what are these 7 or 8 areas that predict your success in adopting technology and changing the business model. We found that 100% of health systems that we surveyed in the alpha format were doing digital technology pilots, but that fully 50% of pilots were successful. In other words, we tried it, it worked, we can adopt it, it can add value, all the things you need to have to actually denote something to be an innovation. We still didn't implement it. And another manifestation of these 4 things is what I like to call the healthcare manufacturing schema. So in automobile industry, it's pretty clear what the manufacturing schema is, right? You got raw materials, steel. You have tools, welders, robots, painting machines, et cetera. You have labor, shrinking, but still, some humans involved. And at the other end of the schema, out comes a car. So you might be inclined to think that our healthcare manufacturing schema is on the top here. Raw materials are people. The tools are anything that works, diagnostic, treatment, otherwise. And our product is health. But that's not our schema. Our schema is the one below. Our raw materials are sick people. Our tools are diagnostic and treatment tools. And what we produce is, yes, recovery from acute illness, but primarily what we're interested in producing is revenue and market share. When your health system CEO stands up at a national meeting to talk about St. Elsewhere system, this is what he or she says. This is how they always start the discussion. St. Elsewhere is a blank billion-dollar healthcare delivery system. Why is that the first sentence that comes out of the CEO's mouth? Patients don't give a damn about how many $1 billion the delivery system is. What they care about is being healthy. But we're not structured. Our manufacturing schema is not structured necessarily to use these incredible tools that we're creating and that you're creating that are being developed. And so this is going to be a change that is process, structure, and technology. Technology in and of itself is useless. I could buy an Indianapolis 500 race car, put it in my driveway, and my 9-year-old would not know what to do with it, right? It would sit there. My 19-year-old wouldn't know what to do with it, even though he can drive. But we've tried process and structure alone. So we've tried optimizing manpower in healthcare 25 years ago, not enough doctors. Let's create new medical schools. Let's train more physicians, start new residency programs, right? Not enough process, so we've all been leaned in Six Sigma over the last decade. That's good. Not enough platform technology, so we all adopted EHRs. When I was in the executive suite 10 years ago, we used to say that, once we get this EHR, everything's going to be better. So they've all been necessary but not sufficient. And we need these emerging technologies to be developed to change the business model, to change the delivery model from the 2 boxes. So just a quick advertisement for the 360 index. And so if you believe that landing these digital technologies on landing strips in your delivery system is necessary to change the delivery model, if you think that manpower optimization, process improvement, and platform technology adoption is not enough, if you believe that that's necessary but not sufficient, that these other tools must be implemented, well then there's some things you probably ought to be working on to create those landing strips. And so the 360 index that we'll be rolling out this year, we're currently working on it with Deloitte and HIMSS. We'll be measuring your capacity in these 7 areas, and hopefully we'll be getting more insights about how to land those planes. Thanks.
Thank you, Roy. I want to move quickly to Dr. Bob Wachter, who many of you already know because he's now a New York Times best-selling author for The Digital Doctor. But he's also been a very important person in our institution for many years, and he coined the phrase the hospitalist, and he's led that program through its pioneering days into its absolutely entrenched and established and relied upon field now. So I'm going to quickly switch over to Dr. Wachter so he can have time to fill us in on his perspectives.
Thank you. Good morning. It's terrific to be here, and this is a very exciting conference, an incredibly exciting time to be in medicine. Let me start out by declaring a conflict of interest. It's traditional that we do that in these conferences. And that, of course, mine is that I'd love for you all to go out and buy my book, which, as Aenor said, is actually doing quite well and seems to be generating a little bit of a national conversation around the subtitle, which is Hope, Hype, and Harm at the Dawn of Medicine's Computer Age. I think we were all spoiled by our iPhones. I think we came to believe that all you do these days is download an app and off you go. You're finding the nearest Starbucks or making a restaurant reservation. And I think we've come to recognize that this is much harder than it looks. And what I try to do in a year of research and interviewing about 100 leading players from all sorts of walks of life was try to understand for myself why that was and sort of articulate a path forward. Now, just a word about the book business. When you launch these days on Amazon, you are number 8 millionth on your Amazon ranking list, and you start clawing your way up. And it's done pretty well, but there are periodically disappointments. This happened to me a couple of weeks ago. I searched on my book, put in the term digital doctor in the search box, and let's see if this gets moving here. There we go. First thing that came up was mine. The second thing that came up is Dr. Romance Medical Erotica. The Billionaire Doctor's Erotic and Romantic Hospital Bachelor short story. This was disconcerting enough knowing that this is what I'm competing against. And then ultimately, it's not advancing. There we go. Ultimately, I noticed that this is free. So it's actually quite tough these days, but we're doing okay. I think I need a new clicker or something because this is not going forward. There we go. The context, and I think Reed brought this up, and Roy brought this up a little bit as well. I want to point out that there are two revolutions going on simultaneously. We're here to focus on the digitization of the U.S. healthcare system, which is clearly happening by every metric that you want to look at, investment, adoption curves. But there's a second revolution, which is the pressure to deliver high-value care, and I think Reed went through that very well. I think you can't understand what's going on and the forces for improvement until you really understand that both of these are pretty new. That until 10 years ago, there was essentially no pressure on doctors, delivery systems, healthcare organizations, anyone else really to deliver high-value care. Now that's odd, and this happened a couple of years ago. I was speaking to the medical students at UCSF who are brilliant and incredibly enthusiastic, and I kind of decided I wanted to shake them out of their complacency, and I said, you folks are entering a field that is wildly different than the one I entered when I went to medical school 30-ish years ago, because you will be under relentless, unremitting pressure to figure out how to deliver the highest quality, safest, most satisfying care at the lowest possible cost. I really wanted to shake him up. And one of the students raised his hand, and he said, what exactly were you trying to do? And I think that's an absolutely brilliant question, because on a bad day when we're all struggling with all of these new pressures, regulatory pressures, payment pressures, transparency pressures, I think it's worth remembering that what is odd is not that we're under those pressures. What is odd is that we weren't until 5 or 10 years ago. And so it's not like it's easy, but this is clearly the world that we're in now and we will be in forever. You've all seen versions of this. I know I went through the sort of adoption curve that we're seeing in terms of all sorts of new technology tools. Those of us who work in enterprises, whether it's in hospitals or doctors' offices, this is probably the most relevant adoption curve, which is that the rate of EHR adoption, this is hospitals, but doctors' offices mirror this curve. The rate of EHR adoption was growing, but growing at a snail's pace in 2008, 2009, 2010. And starting in 2010, the U.S. federal government saw fit to throw $30 billion at this problem. That's the high-tech incentives passed really as part of the rescue of the economy. And whatever you think about meaningful use, and many people, including myself, are not all that enthusiastic about where it's gone, but I think it's fair to say that if the metric was, can we get healthcare to go digital, the answer is the $30 billion of incentives really worked. And I think we will look back on that and say that that was a wise policy maneuver, because clearly this is a market failure. A 10% adoption rate in 2009 in American hospitals shows that the market was not creating digitization in a way that we really needed. Has it worked? Has it gone well? Clearly not. Let me give you three examples that I found from kind of going around the country that convinced me that it was not going as well as we would like. This is Rich Barron, who's now the CEO of the American Board of Internal Medicine, but for 30 years was a primary care doc in a small practice in Philly. He adopted his office-based EHR in 2005, so he was an early adopter type. He was excited about it. They put it in. They tried to prepare. They got everybody on board. And then he told me the staff came to work one day and nobody knew how to do their job, which I thought was an incredibly profound comment. And what it says is that digitization of your analog processes is not just tomorrow, things are a little bit faster, a little bit slicker. You actually change everything about the work. And I think we've given that almost no thought as we've digitized everything that we've done. I think Roy made that point as well, and I think it's a crucial point. We actually have to completely rethink the work in a digital era, and I think we've been quite immature and a little bit naive about that need. Few of us have done that. Second thing that I wanted to highlight in terms of how we kind of underestimated how tough this is, Secretary of Health Michael Levitt said in 2005, we have the capacity to transform health with one thunderous click of a mouse after another. Now, how inspiring is that? One thunderous click of a mouse after another. A study a couple of years ago showed ER physicians spend 44% of their time entering data into EMRs, thunderously clicking up to 4,000 times during a 10-hour shift. That is the reality of clinical practice today. And finally, one of my favorites, in 2014, this was an advertisement that I came across for an ER job in Arizona. And here it is, Arizona General will be coming to the Grand Canyon State later this year. Located in Levine, a suburb of Phoenix, it's a 40,000 square foot boutique general hospital. Now, who would not want to work in a boutique general hospital? That sounds just fabulous. And here's what they're touting. They have an ER, which is good if you're looking for an ER doctor. You really do want to have an ER. They have a radiology suite with the latest gizmos, 2 state-of-the-art ORs, outpatient surgery, 16 inpatient rooms, but their biggest selling point, it was the only part of the ad in bold, was they have no electronic medical record. In 2014, a modern hospital saw fit to advertise for a doctor by saying that you can use pen and paper here. It's really quite extraordinary. So just in a couple of minutes, I want to highlight what really is 250 pages of a book, what we've seen. And it's one of the challenges in talking about this and writing about this. I'm the furthest thing in the world from a Luddite. I believe deeply that we have to digitize. And I actually believe that we probably had to go through the stage we're going through to get to a better place. It would not be nice to believe that we could have been smart enough, clever enough to bypass all of the speed bumps that we're feeling now, but I'm actually not sure that was possible. I think we had to do what we're doing now, feel the pain, and innovate and improve our way out of it. Here's what we've seen, and there's a lot of good stuff. The notes are now legible. We're unlocking the geography of care, so telemedicine is just one example of no longer being constrained by the fact that the chart only lives in one place, or the X-ray only lives in one place. That is extraordinarily exciting. New opportunities for patient engagement, obviously a key theme of this conference. Early uses of big data, of course, it's wildly overhyped and we have to be careful about that, but clearly the potential is there and we will get there, and we're beginning to see some examples. And I think very importantly, IT is an enabler of systemness and standardization. So when we went digital at UCSF, one of the first things you have to do is kind of do the equivalent of cleaning out your closet. You have to look at all of your processes and say which ones of these make sense, don't make sense. If we have 37 ways of doing this, can we come to an agreement on one way to do this? Because we have to embed it in the computer. It also creates a way of bringing disparate systems together. I think all of those are very exciting and I think have been positive outcomes of our digitization. What we've seen, well, the notes are legible but useless. Unhappy clinicians with less communication, that's less communication between doctors and nurses, and in many ways doctors and patients, if you look at the phenomenon of scribes or patients coming in and complaining about the doctor not making eye contact. A remarkable lack of user-centered design in the IT tools that we have, really a shocking lack of user-centered design, and when people come to health IT from other industries, they say, I can't believe how bad these tools are. How did this happen? Little to no evidence of productivity gains, certainly all touted. Part of the selling point for the $30 billion of high-tech incentives was that there would be about $100 billion a year of savings in the healthcare system from a RAND study 10 years ago. Another RAND study a year ago showed that the productivity gains that so far have been zero. Alert fatigue, clearly a major problem. And early fights over control. One of the real things that happens once you computerize is that somebody behind the curtain can now influence and constrain the doctor's practice, and we're beginning to see that become an important battleground. Will we ever get it right? I came to believe that we will. And there's a chapter in my book, chapter 27, which some of the critics, the book has gotten actually very nice reviews, but often people say, and there's this funny chapter that feels like it was written by somebody else. A few people have said that he went all Eric Topol on us in chapter 27, because it's actually a very optimistic chapter, and that is because that's where I landed. At the end of the day, I think the situation that we find ourselves in digital health is exciting, but really not very good today. But I can see how we will get to a much better place. As I say, I think we probably had to go through this step now. You may have heard of the productivity paradox, a term coined by MIT professor Eric Brynjolfsson in 1993, not describing healthcare, but describing what happens in other industries that bring in technology. And what typically happens is people say it's going to lead to major advances in quality and productivity, and 2 years go by, 5 years go by, and nothing happens. And everybody says, what went wrong here? And then in about year 5 or 10 or 15, you begin seeing the massive productivity gains. And the answer, according to Brynjolfsson's research and certainly my own impression, is the technology gets better, clearly, but the real secret to unlocking the productivity gains is rethinking the work, essentially reimagining the work. And that's what happens in year 10, 15, as old leaders die off, new folks come in and say, why do we do it this way? And the answer is we did it this way because we just digitized the analog process. And so that is what we need to begin doing. I can see a clear path for us to get better for both patients and clinicians, and reaching that wonderful state depends not just on the technology, it depends on all of the changes in the way we think about the work and digitization. I won't go through this, but that was this idea that it was written by someone else. So no, it was written by me because I'm pretty sure we will get there. My final point is, if you read Ron Heifetz, who's a professor at the Kennedy School, he talks about technical versus adaptive change. Technical change is a cookbook. Technical change is your iPhone. You download an app, you don't even read the instructions, it's easy to use, and you just use it. Adaptive change, as Heifetz says, are problems that require people themselves to change. In adaptive problems, the people are the problem and the people are the solution. And leadership is about mobilizing and engaging the people with the problem rather than anesthetizing them so that you can go off and solve it on your own. I'd say the biggest mistake we made in digital health has been believing that digital health is a technical change. It is the mother of all adaptive change, and the kind of work that you're doing and the Center for Digital Health Innovation, I think, is making us understand that and bringing us to what I'm pretty sure will be a remarkable place that we'll get to sometime in the next several years. Thank you so much.
Thank you so much.